somewhere on this planet, a stroke is happening right now. Not in 5 minutes. Right now. As you read this sentence, a brain is shutting down. Stroke kills nearly 6 million people every single year. It is the second leading cause of death worldwide, and the single most common reason a person ends up permanently disabled. And here is the part that should keep you up at night. In a significant number of cases, the brain sends out clear, specific warning signals, hours or even days before the catastrophic event. The warning comes. Most people just don't know what they're looking at. That is exactly what this is about. Not fear, not statistics, understanding. Because if you can recognize the warning, you can act during the window when a catastrophe is still preventable. Let me start with what stroke actually is, because most people are working with a blurry picture. When people say stroke, they are often referring to two very different medical events. The first is a hemorrhagic stroke. A blood vessel inside the brain ruptures. Blood spills into or around brain tissue, forms a clot, and begins compressing everything around it. Mortality in hemorrhagic stroke is tragically high. The second type is called an ischemic stroke. Here, the vessel doesn't burst, it gets blocked. Blood flow stops to a section of the brain, and the cells in that region begin dying in roughly 4 to 6 minutes. No drama, no warning in the moment, just silent, irreversible loss. Here is the number that puts it in perspective. Ischemic strokes account for approximately 85% of all strokes. So, that is where we will spend our time today. To understand why every minute of delay is so costly, you need to understand how extraordinary your brain's demands actually are. Your brain weighs about 1.4 kilograms, roughly 2% of your total body weight. Yet, it consumes around 20% of all the oxygen you breathe, and nearly a quarter of all the glucose circulating in your blood at any given moment. It is the most metabolically expensive organ in your body, and it never clocks out. The moment its fuel supply is cut, cells begin dying in ways that cannot be undone. That is why stroke medicine operates on a principle of aggressive urgency. It is a race against permanent loss. Now here is something most people never hear explained clearly. For a brain artery to suddenly close off, the groundwork was usually laid over years. The vessel wall was quietly damaged. Cholesterol accumulated. Inflammatory cells took up residence. Plaques formed, calcified, grew. The opening narrowed slowly. The final blockage is not an explosion from a clear sky. It is the last act of a long, silent process. And along that process, the brain usually tries to tell you something is wrong. In medicine, those early warning signals are called transient ischemic attacks, TIAs for short. The word transient means temporary. They come, they go, and because they go, people dismiss them. Picture a carotid artery, the main vessel in your neck that carries oxygenated blood from your heart upward into your brain. Over years, a fatty plaque forms on its inner wall, slowly narrowing the passage. Then one day, the already tight vessel undergoes a brief spasm. Blood flow stops to the brain area it feeds for a matter of seconds or a few minutes. You experience something that feels strange, alarming, then inexplicably normal again. The spasm relaxes. Blood returns. You breathe a sigh of relief and tell yourself it was nothing. But research tells a very different story. A transient ischemic attack very often directly precedes a major ischemic stroke, typically within the following 72 hours. Those 3 days are your window, the one where intervention can still change everything. Most people don't use that window because the warning episode was brief, bizarre, and then vanished. So they talk themselves out of acting on it. These warning episodes usually last anywhere from about 30 seconds to 10 minutes. That brevity is precisely why they slip through the cracks. You could be washing dishes, walking to your car, sitting in a meeting, and by the time you pause to register what just happened, it's already gone. But each of those episodes is a precise, urgent signal from your brain. I am on the edge. Act now. Let's walk through the 5 major warning signs. Not just what they look like from the outside, but what is actually happening inside the body when each one occurs. The first warning sign is temporary blindness in one eye. Imagine you stand up, take a step toward the kitchen, and suddenly one eye goes dark. Not blurry, dark, like a curtain being drawn or a lens smeared with gray. You rub the eye. Within seconds, maybe a minute, the vision comes back completely. You chalk it up to standing too fast. You forget about it by dinner. What actually happened is this. A tiny fragment of plaque or a small clot broke away from the wall of your carotid artery and traveled upward. It drifted into the artery that supplies blood directly to the eye, a vessel called the ophthalmic artery, which branches directly off the internal carotid. When the fragment wedges into that tiny artery, blood cannot reach the retina. The retina, the light-sensitive tissue that translates what you see into signals, goes dark. No blood, no signal, no vision. Then the fragment drifts onward. Blood returns, and so does your vision. You feel like you got lucky. You were lucky because that same fragment, 2 millimeters from its path, could have entered a brain artery instead of the eye artery. And if it had, instead of 30 seconds of darkness in one eye, you'd be looking at permanent paralysis, loss of speech, or death. Neurologists have a Latin term for this one-eye blackout, amaurosis fugax. It translates to fleeting blindness. When a patient describes this to a neurologist, it functions like a fire alarm. Urgent imaging, urgent evaluation. The stroke risk in the hours following this episode is not theoretical. It is well documented, statistically significant, and often heartbreakingly preventable. Physicians who work in emergency stroke care will tell you about patients who ignored this symptom 2 or 3 times, and the next episode wasn't the eye, it was the brain. The second warning sign is sudden numbness or tingling on one side of the body. The medical term is paresthesia. Think of it as your nervous system dropping signal. It can affect an entire arm, just the hand, half the face, or one full side of the body. It feels like pins and needles, like cotton under the skin, like a limb suddenly wrapped in rubber. It appears without warning, not after sleeping on your arm, not after sitting in an awkward position. You are simply going about your day, and one side of your body stops feeling normal. A few minutes pass, the sensation fades. Everything seems fine. When you sleep on your arm and wake up numb, the problem is mechanical. A nerve was compressed. Blood flow was restricted by posture. Shift position, wait 90 seconds, and the nerve wakes back up. This is entirely different. In a TIA, the problem isn't in the arm. It isn't in the hand. The problem is in the region of the brain responsible for processing sensation from that arm or that hand. That region briefly lost adequate blood flow, and when the blood flow returned, so did sensation. One of the most clinically important details to understand is this. Stroke and TIA symptoms are almost always one-sided because each hemisphere of the brain controls sensation and movement on the opposite side of the body. When both hands go numb simultaneously and evenly, that pattern more commonly points toward the cervical spine, the neck, rather than the brain. But a sudden, unilateral numbness that resolves on its own, with no positional cause, is reason to seek evaluation. Do not explain it away. Have that conversation with your doctor. The third warning sign is a sudden, unexplained loss of coordination. People describe this as being drunk without having had a single drink. You are on familiar ground, your hallway, your kitchen, your office, and without any warning, your foot lands wrong. Your leg feels rubbery. You veer into the wall. Or you are standing still when a sudden, violent spinning sensation hits. Not the gradual dizziness of dehydration, not the familiar inner ear wooziness of a long drive, but an abrupt feeling that the room itself has lurched sideways. You grab the counter. You grab the door frame. The episode passes in moments, and you feel embarrassed. The part of your brain responsible for smooth, coordinated movement is the cerebellum. It sits at the lower back of your skull, compact, dense, and extraordinary in its function. Every second of every day, it is calculating where your limbs are in space, how much force each muscle needs to apply, how to keep your body moving smoothly instead of lurching and stumbling. It does this silently, automatically, below the threshold of conscious thought. The cerebellum receives its blood supply through arteries that travel upward through the bones of the neck into the back of the skull, what's known as the vertebrobasilar system. If blood flow through those arteries drops sharply, even briefly, the cerebellum essentially loses signal. And when the cerebellum loses signal, you lose coordination. You stagger, you veer, you feel the ground tilt beneath you. In clinical practice, these episodes are frequently dismissed as fatigue, low blood pressure, or worn-out shoes. They are explained away because they resolve. But when a person experiences sudden, intense dizziness with no obvious trigger, not rolling over in bed, not a rapid head turn, not a known inner ear condition, combined with any difficulty walking straight, that combination needs to be medically evaluated for a vascular cause. Not assumed to be benign. The fourth warning sign lives in your speech. Before going further, it's worth making a distinction that matters. If you occasionally cannot pull up a word, a neighbor's name, the word for the kitchen gadget you use every day, that is a perfectly normal tip-of-the-tongue moment. It happens more when you're tired, when you're stressed, when you're doing 3 things at once. That is not what we are talking about. What neurologists watch for is something categorically different. A sudden, severe breakdown of speech that feels alien even to the person experiencing it. Most people have 2 primary speech centers, both typically located in the left hemisphere of the brain. The first, often called Broca's area, is responsible for the mechanics of producing language, sending precise instructions to the muscles of your tongue, lips, jaw, and throat so that words form correctly. When this area loses blood flow, even temporarily, something strange happens. The person knows exactly what they want to say. They can hear the question. They understand it fully. But when they open their mouth, the words come out wrong, slurred, chopped, incomplete, or don't come out at all. The thought is there. The language pathway is not. The second area, often called Wernicke's area, handles something different: comprehension and the organization of language into coherent sentences. When this region is affected, a person may speak fluently with what sounds like confident, normal cadence, but the words are jumbled, nonsensical, disconnected from meaning, and they may not understand what is being said to them. They seem unaware that what they're saying doesn't make sense. Either pattern, garbled output, word salad, or sudden inability to find words at a severity you have never experienced before, appearing suddenly, and then fading in a matter of minutes is a textbook sign of a TIA, not a momentary lapse. Ignoring recovered speech failure because it went away on its own is like an alarm going off in your home, stopping by itself and deciding it probably wasn't serious enough to check on. The fifth warning sign is less obvious and often surprises people entirely. It is the combination of a skin condition called vitiligo, appearing alongside new, unusually intense or frequent headaches that don't fit your normal pattern. Vitiligo produces patches of pale or completely white skin where the cells that create pigment, melanocytes, have stopped functioning. This happens because the immune system mistakenly identifies those cells as foreign and attacks them. It is an autoimmune process. Here is why that matters for stroke risk. When an immune system goes off target against one type of cell, it frequently does not confine itself to that one type. In a meaningful number of people, the same autoimmune activity that attacks melanocytes can also produce chronic, low-grade inflammation of the inner lining of blood vessels, a microscopically thin but functionally critical layer of cells called the endothelium. Think of the endothelium as the interior surface of every artery in your body. When it is healthy, blood flows smoothly along it. Nothing clings, nothing accumulates. When it is damaged by chronic inflammation, its surface becomes rough, scarred, reactive. Cholesterol particles, platelets, and inflammatory proteins begin adhering to those rough patches. Over time, they build into the plaques that narrow and stiffen arteries, the very plaques at the center of ischemic stroke risk. Vitiligo alone does not predict stroke. But when a person with vitiligo begins experiencing headaches that are new in their character, stronger than usual, more frequent, paired with any of the other warning signs we've covered, that combination warrants a proper vascular evaluation, not watchful waiting. It's also worth understanding something about headaches more broadly, because there is a common and costly confusion. A very frequent source of daily or recurrent head pain has nothing to do with the brain's blood vessels at all. Degenerative wear in the small joints between the second and third cervical vertebrae, essentially arthritis in the neck, can compress and irritate nearby nerves, sending referred pain upward into the head in a pattern that mimics vascular headache. Separately, undiagnosed cervical disc herniation is more common than most people realize, and in severe cases can threaten the nerve supply to the arms and legs. Headaches should be evaluated, not simply muffled with painkillers indefinitely. They need to be decoded, particularly when they change in character or arrive alongside any of the warning signs in this video. Now, let's talk about the internal environment that creates these crises, because one of the most persistent myths in public health is that stroke risk is primarily about cholesterol. Your cholesterol numbers matter, but the full picture is the condition of that endothelial lining we've been discussing, the interior surface of your arteries. Think of it like a non-stick pan. As long as the coating is undamaged, nothing adheres. Once it's scratched and worn, everything sticks and accumulates. The first major threat to the endothelium is chronically elevated blood sugar. Glucose is the primary fuel for your cells, including the cells that line your arteries. But for glucose to enter those cells from the bloodstream, it needs insulin, the hormone that essentially unlocks the door. When the body doesn't produce sufficient insulin, or when the cells have become resistant to its signal, something paradoxical happens. Glucose is abundant in the blood, while the very cells of the vessel lining are starving for it. Starving cells lose their structural integrity. They become damaged, lose their shape, and in some cases begin to slough away, leaving behind roughened, scar-like surfaces. Those surfaces can no longer expand and contract properly in response to changing blood pressure, a condition called loss of vasomotor reserve. And those rough patches are, in effect, landing pads for LDL cholesterol, platelets, and circulating inflammatory proteins, the building blocks of plaque. This process begins long before anyone labels it diabetes. In the stage called prediabetes, where blood sugar is modestly elevated but hasn't yet crossed the diagnostic threshold, vessel damage is already accumulating, quietly, silently. The second major threat is cigarette smoking. Tobacco smoke contains thousands of chemical compounds, dozens of which have established cancer-causing effects. But from the perspective of stroke, the specific danger is what those compounds do to the endothelium and to the blood itself. Every cigarette delivers a direct chemical assault on the inner surface of your arteries, triggering inflammation and structural damage. Simultaneously, nicotine and carbon monoxide make the blood itself more viscous and sticky. Platelets clump more easily, clots form more readily. Combine a damaged vessel wall with thickened, clot-prone blood, and you have constructed, systematically, the ideal environment for an artery to block. Smokers carry approximately 2 to 4 times the ischemic stroke risk of non-smokers with comparable cholesterol and blood pressure profiles. Blood pressure adds another layer of complexity because there is a myth that runs in both directions here. Yes, chronically high blood pressure, hypertension, is among the most powerful known risk factors for stroke. Over years, the mechanical force of elevated pressure physically stresses vessel walls, accelerates plaque formation, and is the dominant driver behind hemorrhagic stroke, where a weakened vessel ultimately ruptures. But here is the element that almost no one outside of stroke medicine understands. An ischemic stroke often doesn't happen at the peak of blood pressure. It frequently happens at a relative low point. Consider a brain artery that has been narrowed by plaque, perhaps by 50 to 60% of its original diameter. It functions like a garden hose someone has pinched in the middle. As long as water pressure in the system is high enough, some flow still makes it through the constricted zone. But when overall pressure falls, flow through the narrowing drops sharply. If a small clot has formed on the plaque, which is common, even a modest pressure drop can stop flow entirely. During sleep, blood pressure drops naturally by approximately 15 to 20%. This is a healthy, normal physiological pattern. But for a person with significantly narrowed arteries, that nighttime dip can convert a partial blockage into a complete one. The vessel was already compromised. The pressure drop was the final variable. This is why some people go to bed feeling completely normal and wake up or are found with stroke symptoms. Age shapes risk in ways that go beyond the oversimplified narrative. Risk does rise substantially after 50 and roughly doubles with each additional decade. In older individuals, the dominant mechanisms are atherosclerosis, hypertension, and cardiac arrhythmias. But approximately 10 to 15% of strokes occur in people younger than 45. In younger patients, the picture looks different. Congenital vascular abnormalities, cerebral aneurysms that rupture without warning, inherited clotting disorders, autoimmune conditions, and trauma to the head or neck are among the leading drivers. And there is another critical age-related factor. After approximately 40, the rate at which risk factors like smoking, high blood sugar, and elevated pressure damage arterial walls accelerates, roughly twice as fast as it did during your 30s. The same habits produce faster damage in the body you have at 45 than in the body you had at 35. This is one reason physicians become more direct and specific about risk factor management as patients move through their 40s and 50s. So what do you do if you have already experienced even one of the 5 warning episodes, even if it lasted under 10 minutes and went away completely? You have approximately 72 hours in which meaningful prevention is still possible. The goal is not panic. The goal is to use the window you've been given. One of the first things stroke specialists consistently emphasize is that people should not be alone in the hours following a suspected transient ischemic attack. This is worth thinking through in advance, not after an episode has already occurred. If you live alone, make sure someone you trust knows what happened and can check on you or reach you quickly. If another episode occurs that is more severe, sudden inability to speak, sudden arm weakness, sudden facial drooping, another person needs to be present to recognize it, call emergency services, and stay with you until help arrives. Driving yourself anywhere after a suspected TIA is medically inadvisable. Losing vision or motor control for even a few seconds at highway speed is not a personal risk. It's a risk to everyone around you. Speak with your healthcare provider in advance about what your plan would look like if something like this happened, so you're not improvising in the moment. If you or someone with you is able to measure blood pressure and the reading shows a top number around 180 or higher, with a bottom number around 110 or higher, that is not just elevated blood pressure. That fits the criteria for a hypertensive crisis. In that scenario, contacting emergency services is what standard guidelines recommend, not waiting to see if it resolves. Ask your doctor explicitly what threshold they want you to treat as a medical emergency, so you have a concrete number to act on. One rule from stroke medicine is absolute. Do not begin blood-thinning medications, aspirin, anticoagulants, or any similar drug on your own, based on advice from a friend, a family member, or something you read online. The reason for this is fundamental. There are 2 types of stroke: ischemic stroke, where a vessel is blocked, and hemorrhagic stroke, where a vessel is bleeding. Blood thinners can be beneficial in certain ischemic situations. In a hemorrhagic stroke, they can accelerate and enlarge the bleeding, with potentially fatal consequences. Without a CT scan in a clinical setting, no one can tell which type of stroke is occurring based on symptoms alone, not even an experienced physician. The right action is evaluation, not self-treatment. While waiting for medical help, body position matters. Lying flat is generally preferable to sitting upright, as it supports blood flow to the brain. A comfortable flat position, with the legs slightly elevated above chest level, is often recommended to ease the heart's workload and support circulation. Keep the head in a neutral position, not bent sharply forward and not extended backward, so the neck vessels are not kinked. Avoid smoking, alcohol, hot baths, or prolonged hot showers in this period, as sudden vasodilation in an already unstable vascular system can worsen the situation. Discuss these details with your own physician to confirm what applies to your specific health profile. A small practical measure that saves real time in emergencies: keep a current, written list of all medications you take regularly somewhere easy to find. Emergency teams can act faster when they don't have to reconstruct your medication history. And if 72 hours pass without a new episode, you have not been cleared. You have been given a second chance. Use it. There are 3 specific investigations worth asking your doctor about if you have experienced any of the warning signs we've discussed, even weeks or months ago. The first is a carotid duplex ultrasound. This is not a basic ultrasound that simply shows anatomical structure. Duplex imaging shows both the structure of the artery and how blood is actually flowing through it in real time, whether flow is smooth and laminar or turbulent and disturbed at a narrowed segment. If the carotid artery is found to be narrowed by more than roughly 70% of its original diameter by plaque, physicians refer to this as hemodynamically significant stenosis. At that level of narrowing, the question stops being whether a stroke could occur and becomes a matter of timing and circumstances. At that threshold, surgical intervention, a procedure called carotid endarterectomy, in which the artery is opened and the plaque physically removed, may be recommended. In modern vascular surgery, this is a well-established procedure performed routinely at experienced centers and has been shown to substantially reduce subsequent stroke risk in appropriately selected patients. If you have risk factors for vascular disease, or if you have ever experienced any of the warning episodes described in this video, a carotid duplex ultrasound is a reasonable and direct question to raise at your next medical appointment. The second test is glycated hemoglobin, known as HbA1c. Hemoglobin is the oxygen-carrying protein inside your red blood cells. When blood sugar is elevated, glucose molecules chemically attach to hemoglobin. They become glycated. The higher blood sugar has been over time, the greater the percentage of your hemoglobin that carries these sugar attachments. Since red blood cells live for approximately 3 months, the HbA1c result reflects your average blood sugar across that entire window, not just a single morning reading. You cannot game it with 1 day of careful eating before the blood draw. This makes it uniquely powerful for identifying the pre-diabetes zone, where blood sugar has been high enough, long enough, to quietly damage the endothelium, but hasn't yet crossed the threshold where anyone has told you that you're diabetic. The clinical reference points are clear. HbA1c below approximately 5.7% is normal. Between 5.7% and 6.4% is consistent with pre-diabetes. At 6.5% or above, the picture is generally consistent with diabetes. If you haven't had this test, or if it's been several years, it is straightforward to request, particularly if you carry any stroke risk factors. It is one of the most informative single tests available for assessing the silent damage that precedes cardiovascular events. The third investigation is Holter monitoring, a 24-hour continuous recording of your heart's electrical rhythm. A standard ECG taken in a clinic lasts 10 to 20 seconds. That snapshot, however clear, will miss any arrhythmia that isn't happening in that precise moment. Holter monitoring attaches a small portable recording device to your chest and captures your heart's rhythm continuously across a full day of normal activity, waking, working, sleeping. The rhythm most urgently linked to stroke risk is atrial fibrillation, commonly called AFib. In AFib, the upper chambers of the heart stop beating in a coordinated, organized pattern, and instead quiver, chaotically contracting at rates that can reach several hundred beats per minute. Blood no longer empties smoothly from those chambers. Instead, it churns, and in churning, stagnant blood, clots form readily. When those clots eject from the heart, travel through the arteries to the brain, and lodge in a cerebral vessel, the result is called a cardioembolic stroke. These strokes are often severe, frequently affecting large regions of the brain. Many people with AFib experience few or no dramatic symptoms. At most, they notice occasional palpitations, a flutter they attribute to caffeine or stress, or a vague sense of something being slightly off. Holter monitoring catches the hidden episodes that surface sporadically. If AFib is identified, there is a well-established class of medications, anticoagulants, that when prescribed and monitored by a cardiologist can reduce stroke risk from this specific cause by approximately 60 to 70%. That is not a modest improvement. That is the difference between a life that continues as expected and one that changes in an instant. Step back from the specifics for a moment and hold the larger picture. Stroke is not a bolt of lightning from a clear sky. It is, in the overwhelming majority of cases, the predictable final event in a years-long process of silent vascular degradation. And in a significant portion of those cases, it announces its approach before it arrives. You now know the 5 signals to watch for. Temporary blindness in one eye, appearing and fading within minutes. Sudden numbness or tingling on one side of the body without any positional cause. Abrupt loss of coordination or balance. The unexplained drunk walk. A sudden, severe breakdown in speech that self-resolves. And the combination of vitiligo alongside new, uncharacteristic headaches that don't fit your normal pattern. Any one of these appearing for the first time, even if it lasts only 60 seconds and leaves no trace, is reason to seek urgent medical attention and ask specifically whether you should be evaluated for TIA and whether carotid duplex ultrasound, HbA1c, and Holter ECG monitoring are appropriate in your situation. On the prevention side, the evidence is consistent and actionable. Keeping blood sugar within a healthy range and catching prediabetes early through regular HbA1c testing protects the endothelial lining and slows the formation of the plaques that narrow arteries. Managing blood pressure in partnership with your physician, with the goal of avoiding both chronic excess and sharp falls, reduces the mechanical stress that damages vessel walls and lowers risk of both ischemic and hemorrhagic events. Stopping smoking with clinical support if needed removes a continuous chemical assault on your arteries. Over time, it reduces ischemic stroke risk by a factor of 2 to 4. And perhaps most practically of all, do not wait for a brief neurological episode to seem serious enough to warrant attention. Brief is exactly how TIAs present. Brief is the warning. If the warning goes away before you act on it, you have not escaped danger. You have spent part of your 72-hour window. If you recognize any of the 5 warning signs from your own experience, even from months ago, write them down. Be specific about what happened, how long it lasted, and what it felt like. Bring that written account to your physician. Do not rely on memory under the clinical pressure of an appointment. Ask your doctor directly, does this pattern suggest I should be evaluated for transient ischemic attacks? Should we look at the carotid arteries, the long-term blood sugar picture, or the heart rhythm? If you carry known risk factors, elevated blood sugar, high blood pressure, smoking history, autoimmune conditions, use what you've learned here to have a more specific conversation with your doctor than everything looks fine. Ask for the numbers. Ask what the plan is. Ask what threshold should prompt an emergency response. Your brain has been trying to protect you. It deserves you learning its language. This video is for educational and informational purposes only. It does not constitute medical advice and is not a substitute for consultation with a qualified healthcare professional. If you believe you are experiencing a stroke or neurological emergency, contact emergency services immediately.